get started. All right, welcome everyone back to day number 2. So I'm Krista Eschbach, pediatric epileptologist in Colorado, and I will be walking us through our plan and agenda for today. So I'm going to start with sharing my screen. We'll go over a few kind of housekeeping items and the plan for the morning or afternoon for some people or evening. One second, let me just Okay, so I think everyone can see my screen now. So here is, oops, see if it moves forward. There we go. So here's our agenda. We may end up adjusting the order just a little bit of things, but just to let people know what to expect. The focus for today is going to be on discussions around, we talked about the phases 2 days ago and how those can look in NORSE and FHIRS, but thinking about how our treatments are during those times and what we call, de-escalation or changing or taking away treatments and what that looks like. So we'll talk about that for the acute and chronic, and also thinking about kind of the immune treatments too. And I know some questions came up about that on Tuesday, so I'm hoping we can address some of those today. Just a few housekeeping things as well. So please keep yourself muted unless you're speaking. Feel free to use the chat to ask questions, and we'll address those either through the chat or during the Q&A sessions that we have planned. If you experience any technical issues, let us know in the chat. We'll have people watching for that to be able to give some guidance. There is the option to use translation through Zoom. Please let us know if anyone needs help with that setting. I think from my understanding, and Adam, I don't know if you want to chime in, but there's, if you want to just briefly say how people can access that.
Yeah, sure thing. So for those who need it, you can go to settings and more with the 3 dots. And then there's one icon that says show captions. You'd select show captions. And from there, you should be able to select you'll see the hide captions, and then there's a little arrow that you can press, and then there's a translation button. And if you select that, you can then have a drop-down menu that you can select any language that you'd like from there. And then it'll translate from English into your preferred language.
All right, thank you. We meant to mention that the other day. Want to acknowledge that we have people, internationally that are joining, and want to make sure everything's as accessible as possible to everyone. And then as a reminder, again, just like with on Tuesday, we are fortunate to have a combined symposium this year, including clinicians, researchers, patients, and families throughout both days. And so we'll try and make sure we are addressing kind of the entire audience and clarifying things as needed. All right, let me go on to my next slide. So the first thing we'll start with is thinking about treatment de-escalation and how to decide. And I'm just going to give a little bit of a background, and then we'll hear more about this from some of our speakers, and also have a kind of a panel discussion and a chance to ask some Q&A of our speakers as well. And so over this time, we'll think about the approach to the treatment of NORSE, including treatment for refractory status. We touched on this a little bit yesterday, so I'm not going to go into all the details of it, but just want to set the stage for, as we talk about how to pull things away, all the different treatments that some of the patients might be on, which I know, for our patients and families on, they've, experienced this and the number of different treatments that can sometimes be added. We'll review the risks of status and of the anesthetic infusions used to treat refractory status, because that's often a balance that comes into play in the ICU, and then explore approaches to duration of treatment with anesthetic infusions and immune therapy. Kind of, again, just setting the stage for the rest of our talks. So again, here is one of the figures from Dr. Wickstrom and the consensus guidelines regarding the treatment. So as you see up there at timeline 0, the initial treatment for NORSE is focused on treating the status and refractory status. And that's following, standard published recommendations and guidelines with anti-seizure medications. And so that's where that initial focus is. And on the next slide, we'll talk a little bit about what that is. So first, we'll start with that stabilization phase and giving a benzodiazepine as the initial therapy of choice. And on this slide has a little bit more information about some of the different options and the level of evidence for the different treatment choices. And then if the seizures continue after that initial appropriately dosed therapy, then typically the next recommended treatment option is a selection of picking between 3 IV anti-seizure medications and a large loading dose. And here, they're saying there's no evidence-based preferred second therapy of choice. So you choose one of the following options. And I don't know if you guys can see, but we're at this kind of second phase here. And then you get to the third phase. And this is where, as we get into refractory status at this point, and just highlighting the limited data about specific treatments at that time. And again, our NORSE guidelines talk about importance of immune treatments, but we're going to talk a little bit here too about some of the anesthetic infusions and as they're added and how long to continue them. And so we're kind of in this group down here now. And so these anesthetic medications, the continuous infusions that get added after patients haven't responded to the initial therapies, it's typically midazolam, ketamine, propofol, pentobarbital, and thiopental. And there's lots of I shouldn't say there's lots of, there is different kind of protocols at different institutions. This is one by a paper that came out a few years ago that kind of walks through their pathway at their hospital. It's an adult hospital of how they treat refractory status and kind of going down. They start with propofol, what the doses are. We'll talk some about this idea of burst suppression and ictal discharges, some of the findings we're seeing on the EEG and what we're targeting with that or not. And I also want to add that alongside the anesthetic infusions, we're often also adding on, IV scheduled, anti-seizure medications, and sometimes also enterally, so either through a tube if the patient's not able, it's not going to be able to take anything by mouth at that time. And just want to highlight how many different anti-seizure medications we have at this point. And I know it seems like a lot, and there's been a lot of development in the recent years about this, but also, there does mean that sometimes our patients will end up being on many, many different anti-seizure medications to try and get control of their seizures, both acutely and then also thinking about more long-term as well, and striking that balance between medications and side effects. Which is what we get into here when we think about the balance of the risks of our treatment. So yes, we have these treatments. We want to stop the seizures. We'll see on the next slide kind of the effect that seizures can have as well, but our treatments also can have side effects. So our anesthetic infusions can have an influence on blood pressure, on your heart, on your liver. You're more prone to pneumonia and infections influencing your GI system. And so they are not benign treatments, which is why some of the discussions that we want to have today about duration of treatment and when to de-escalate or pull back on these anesthetic infusions is really important. And we also know that prolonged critical illness and being in an intensive care unit for a long time has its own additional host of additional risks and complications associated with that. And so what is that right balance between our treatments and seizures? We also know that there are risks of status itself, and we'll hear about this more in some of our other talks as well, and about some of those, the EEG patterns and when they may have more risk for ongoing injury or damage to the brain. And so this is just an overview of some of those changes that we see happening. We heard about some of this yesterday as well. And then there also is risks even from status in terms of for cardiac dysfunction, renal failure, metabolic derangements as well. And so really when we're looking at treatment, we're trying to find this balance between our treatments and, the risks of the seizures and the status themselves. And a recent scoping review states, one of the questions that comes up is how much do you need to suppress the activity on the EEG? How much suppression do you need? So for clinicians when we're thinking about burst suppression, so that's more than just seizure suppression where you have bursts of activity and then you have suppression on the EEG. And so do we need to be targeting burst suppression or just seizure suppression? And this recent review would say that for most patients with refractory status, targeting EEG burst suppression does not provide additional benefit over seizure suppression alone. And we'll talk some more about that as well. And then just a couple more slides before we get into our next talk. So when we think about getting to the timing of when to take away our anesthetic infusions, often that is after not having seizures for 24 to 48 hours, we may decide to pull back on them. Again, this is an area that's more by kind of expert clinical practice, and that we need, ultimately we do need more data and really individualized data for each individual patient. What is that best time to start decreasing back on medications? But we do have some data about that weaning anesthetics, and that we do know can be complicated. As you're starting to wean some of these infusions, you can get the emergence of patterns that may be on what we call the ictal, interictal continuum. So it is not definitive seizures, but has patterns that can evolve into seizures and can still be potentially at risk and causing injury. And so kind of that balance. But there is some data that when they've continued to wean despite that, that it did not always result in recurrent seizures or a poor outcome. We do know that there's no significant relationship between the wean duration and the likelihood of success, or between weans that did or did not follow burst suppression, based on one of the articles listed here. You are more likely to have recurrent seizures, though, in the presence of highly epileptiform appearing bursts and epileptiform interburst intervals. EEG background features are also important. So that's depending on what we're seeing in terms of levels of our activity and other features on the EEG, and maybe helpful in predicting the success of the anesthetic wean. And then there's also been some research looking at quantitative EEG measures to try and predict success in weaning off infusions. But again, some of these, we'll hear more about the specifics about some of these, but it can be a really, challenging time to tease through some of what we're seeing on the EEG and whether we keep weaning or not, and where we're at. And here, this image just shows actually in a patient with NORSE, at the top with A, when they were having seizures, B, when they were in a period of burst suppression. So here on the EEG, the suppression period is where things are flatter, and then the burst is this burst of activity in the middle. And then image C is where they had periodic discharges emerge in the setting of weaning the anesthetic infusion. They actually persisted with the wean during that time, though, and ended up here, D is 48 hours following their wean of the anesthetic infusion. So it's just one example of kind of the evolution that you can see in this. Point C here is a tricky point that can make people, very uncomfortable when we're still seeing this amount of discharges and these periodic discharges that are emerging. And are they going to have recurrent seizures or not? And what is the impact of these? So thinking about when should medication be de-escalated, we talked about this a little bit, that current guidelines recommend maintaining continuous IV anesthesia for 24 to 48 hours after seizure control. And then when we think about non-anesthetic anti-seizure medications and immune treatments, I just want to highlight this from another algorithm about the treatment acutely of NORSE, is that similar to our anti-seizure medications and our infusions, where you may end up with many being added, we also have many different immune therapies that are considered, and we'll hear more about those. And so at what point, though, and how long do you continue those for? And I think that's an area I know people had questions about on Tuesday as well, that is important to consider. And some of this, so that same algorithm here on the bottom talks about when you get resolution of refractory status, what to do, and gives a little bit of guidelines that, if you end up with post-acute epilepsy, continuing therapy for 3 months, and then considering decreasing some of your medications. But I think there's often questions, even before we get to that point, about, as we mentioned, for the continuous infusions, when and how to taper, how long to continue the non-infusion anti-seizure medication. Sometimes our patients are on very high doses of phenobarbital. So when is the time that we would continue, make any decreases in that or not, what to do with immune therapy, if it seemed to help, how long to continue. And then I just want to acknowledge on the flip side, there are, patients where despite all of our treatments, the status epilepticus continues. And so how to balance the risks of escalating continuous anesthetic infusions if we're still seeing seizures, how many seizures are okay to tolerate, and when to escalate farther with immune therapy in these scenarios. And these are some discussions that I hope we can go over in our panel discussion, which is what we'll go to, I believe, next, if everyone is on. Let me just see. I don't know, Nora, I'm just looking. Is Dr. Hirsch on?
He'll be on shortly. I have to resend him the link.
Yeah.
Oh, okay. Okay.
Joining.
Well, okay. Maybe just to let him get settled before we jump in. Well, if he's, I was going to say, oh, we could go first, but you're talking. I guess we'll start. We'll let you guys start. So our panel discussion, we have Dr. Hirsch from Yale, Dr. Tarashenko, who's now at the University of Colorado, Dr. Katsos, who is at Gauche, and then Dr. Riviela, who you guys met yesterday at Baylor, Texas Children's Hospital. And I have several questions that I'm going to pose to our panel. We'll hear more about some of these topics too in the details during their discussions. But certainly people also feel free to put things in the Q&A or in the chat. We have some time set aside to really kind of be able to ask our clinicians their approach in these different scenarios, and also acknowledging that this is an area that there is, as you saw in that first slide, that there is kind of limited evidence about the exact next step in all scenarios. Oops, let me go to my next slide. There we go. And I think my thought for this for our panel speakers is that, if one person wants to answer and everyone else agrees, that's fine. But if you have other things you want to add or chime in on, let me know. So one thing to think about that I was hoping you guys could share is what principles guide your approach to de-escalating therapy in patients with NORSE and fires. So when do you kind of start to make those decisions?
We can maybe start the discussion.
Yeah.
Hi, everyone. I'm Olga Tereshchenko. Currently, we'll be starting at the University of Colorado in a few weeks. I have a talk later to talk about principles of de-escalation and sort of management of chronic seizures in survivals of NORSE. But I think the question here is larger, broad, and we have to understand that sometimes eliminating all seizures is unrealistic. So we have to have some level of tolerance and some thresholds that will keep us comfortable, perhaps to balance the treatments and sort of the seizure burden. And sometimes it's very tricky and patient dependent. So definitely if the seizure burden goes down, if the convulsions are reduced in an acute state, after about 48 hours of anesthetics, it's prudent to start weaning. And later on, the decision to pull away other anti-seizure medications is very individualized, depend on the clinical condition, medical comorbidities, how far along we are with ICU hospitalization. I think the goal usually is to taper off the medications with the most side effects, such as phenobarbital, perhaps some very sedating medications that would limit recovery and quality of life after the discharge. And once we get to the discharge state, that the waters are completely mothered, if you wish, and they're and I'll touch upon this later on, but it's even more complicated because now you have to manage, definitely consider side effects. The patient now lives in the community or perhaps is in a rehab. You have to think about immunotherapy, you have to think about diets and how it influences rehabilitation and recovery. So I have some sort of landmarks that I can show later on, but overall, we have to be accepting some seizure burden, and we have to balance quality of life and the medication side effects, which is a big point.
Thank you. If any of the other speakers have stuff they want to chime in on, just let me know, or unmute. Otherwise, I can go on to, Dr. Riviela.
Yes, Jim Riviela from Texas Children's Baylor. So we've been looking for the biomarkers in an EEG. Olga mentioned the highly epileptiform bursts, or maybe it was Krista, but we mentioned what are called the highly epileptiform bursts in the EEG. And these have been markers of potential recurrence of seizures that apply to not just fires, NORSE, but to, I think, all cases of refractory status epilepticus. And so if you use the EEG and look for the highly epileptiform bursts, usually by 48 hours, you're still going to have highly epileptiform bursts. I think that in some of the original treatments that we did with status epilepticus or refractory status epilepticus back in the 90s, we were saying that once we got the seizures under control, back then we were mostly using pentobarbital, but once we got the seizures under control, we were backing off within 12 to 24 hours to see whether we had we called it breaking the cycle of the seizures, and whether then people could stay off the infusions. That generally didn't happen in anybody that has an infectious, in my experience, that has an infectious or an inflammatory etiology for their epilepsy. So then we were treating then for 72 hours, because there were some papers back in the 80s and 90s that talked about a duration of therapy of 72 hours. And so I think we do try to taper people in general by 72 hours for cases of status epilepticus, but I can't remember any patient with NORSE fires in whom we successfully tapered them after 72 hours. And I would imagine that we may not even be trying, because many of them are still going to be having ongoing active frequent seizures by that time. And therefore, the reason that we've been urging or recommending that we start the immune therapies sooner rather than later. So we've been using the highly epileptiform burst as a gauge for that. We did have some work here with biomarkers and NORSE fires, where we showed that after anakinra treatment, it took about 2 weeks for those highly epileptiform bursts to convert in the EEG to non-epileptiform bursts. The other thing that I would throw in to follow up on what was said is that seizure burden is important. Seizure burden meaning a percentage of time that you're in seizures. We looked at our data with anakinra, and people, and when I say people, our group was using seizure number as a determinant of ongoing treatment or continuing to escalate treatment. But we found in looking back at it that even though somebody may have had 20 seizures in a day, which sounds like a lot, when we looked at the duration of those seizures, some of them were 10 seconds. And so for some of our patients, we were escalating therapy on the basis of 800 seconds a day out of 24 hours of somebody having seizures. And we realized that that's not ideal. But when we think about ongoing seizures, not only the patterns that we see on the EEG, but if there's some metabolic assessments that we can make during those seizures, such as looking at NIRS, which is near infrared spectroscopy, as a marker of blood flow and metabolism, if you see the NIRS dropping during these interictal or these ictal-interictal patterns, then that's telling us that this is not just interictal, that this may be something that we need to be more aggressive with treating. Now, some of these are invasive studies. Brain tissue oxygenation will drop during some of these patterns. We don't do that, but some of the metabolic assessments may help.
Thank you. That's perfect. You actually led into what I think is the next question. So we'll let, if anyone of our other clinician panels wants to add anything else too, I think thinking about how do biomarkers, so EEG, MRI, PET, any other ancillary testing influence decisions around therapy, de-escalation, and how long to continue infusions for. Marios, you're unmuted.
Yeah, I mean, I'm not sure. I don't know if we actually would make more sense if we should have actually the talks first and then go into this discussion, because we'll probably be repeating a lot of the stuff we're going to be discussing here in this, and it might be better for people actually to see the lack of evidence about all of this, because what you are hearing is actually only opinions. Okay, of course, informed opinions by people who have dealt with the disease, but it's still opinion. And so, in my view, none of these biomarkers actually can guide you on when to really de-escalate treatment, apart from the obvious fact that if the patient has ongoing clinical seizures or ongoing electrical seizures, if you do non-convulsive status epilepticus, then you actually have to continue with treatment, as colleagues said. one only minor comment, because there is families and patients actually here in the group about phenobarbital. I mean, in our experience at least, we use a lot of phenobarbital, and I don't have a single patient who has left the hospital after Norse fires without being on phenobarbital, to be fair. That's my personal experience, my personal practice. And I have to say also, I have found it also very difficult sometimes to win these patients of phenobarbital. Cenobamate has given us some hope. Now that we started at least using it in several children as well ourselves, we started using it at least above 6 years of age. So it has given us some hope, but again, it's not the magic drug as well, and can have also a lot of side effects in combination with phenobarb and clobazam. So yeah, I would say it's none of these biomarkers is guiding other than the very obvious clinical factors.
Thank you. Yeah. Dr. Hirsch?
Yeah, hi. Apologies for being late and maybe messing up your schedule. I don't know if I will be talking about seizure burden and a lot of those markers and things. If you want me to do that before the rest of the discussion, or let me know what kind of.
I think this is the main one that some of the other ones won't overlap quite as much. We have some questions in the chat too. So yeah, if you want to add more during your talk, or if you want to add anything about it now.
I don't see questions in the chat on the
Yeah.
part that's visual to me.
Yeah. I will. So we have one, so we'll come back to the biomarkers for your talk. We have, I think, a couple of questions that I want to highlight for our clinician panel. So someone mentioned, when can families have input into de-escalating therapies, and at what point in the process? If anyone wants to take on that one, I think it relates some to what we had talked about on Tuesday too, in terms of communication and what's happening in the ICU, but also as we're talking about chronic treatments too.
Well, if I mean, I could just comment to say that we try to have families involved with every decision that we make with our patients, including the escalation. Now, if someone's in the midst of, a convulsive status epilepticus that doesn't stop, we're going to be doing certain things to try to stop that. But if we're talking about seizures that have been under control, and then we see seizures coming back, and then we're deciding on escalation, like I said, we tend to talk to our families about every point. So I believe, yes, they should be part of escalating therapies. But I could imagine if they could comment from their points of view, it may be very difficult in the first several days of this, and especially if somebody's in a convulsive, long-standing status epilepticus, that it might be difficult for them to do that. But yes, we try to involve them at all levels.
I would just add that definitely in the chronic management, we listen to the families. It's very important. We don't see patient most of the time. They just come for the appointment. So definitely information about side effects, comorbidities, psychiatric comorbidities that may or may not be brought about by seizures or our treatments are very important for that decision. And overall, how our treatment affects the recovery. So that's very important feedback that we would definitely take from the families in post-acute state.
And I'm sorry, I was also talking about escalation, but certainly de-escalation, yes. Because for de-escalation, I guess if you asked all of us on the panel how we de-escalate our patients, I don't think any one of us would give the same answer. So what that means is that there's going to be multiple different ways to do this. And certainly, family input is important in that. We had a recent patient in whom and of course, we have the other problem in the treatment of this disorder where there's multiple teams involved, and not just from one team, but like in our center, the neurocritical care team switches every week. So you may have multiple providers, but we try to involve the families in that a lot. We had a recent patient who was having a lot of still clinical and electrographic seizures on the EEG, and we had a difference of opinion as to should we escalate or de-escalate? And after discussion with the family, some of us decided to de-escalate, and we got the patient off of the infusions and got him to the point of where he was very functional. And I think if we hadn't de-escalated, he would have been, still in a very lethargic or comatose state from the infusion. So I think particularly with de-escalation, that is something absolutely that families should be involved in.
I'll just make a general comment about, I think it's very important to talk to families about the careful balance, not only families, the doctors too, of what we're always doing, because we're not only trying to keep the person alive, we're trying to save brain cells and maximize their future cognition and behavior and preventing future epilepsy. So that's all by limiting the number of seizures, and I'll talk about that some more. And I do use MRI, particularly with restricted diffusion in the area where seizures are coming from. That's always a worrisome sign for me that we're not controlling enough, and there may be some permanent injury going on. But it's always a balance of the adverse effects of all the treatments and the adverse effects from the seizures or highly epileptiform patterns going on. So it's a tricky balance. I think we're starting to learn more about in which patients and how much seizure burden and what type, and it does seem to be associated with worse outcomes or neuronal injury. If you need some rough numbers of that, I try and keep seizure burden below 5%. That seems to be a cutoff where it's associated with worse outcomes. But of course, it's not so straightforward where a single number can be the cutoff. And then withdrawing, yeah, that gets tricky with the de-escalation. You certainly don't want to overreact to every seizure that happens. So you have to say up front, explain that we're going to be willing to tolerate X amount of seizure activity. And there are some withdrawal patterns you also have to be aware of this too, and not to put people back on barbiturates because they're having a withdrawal pattern. So it's all complicated, but as long as the teams and the families know about that careful balance, I think that helps people understand and get on the same page.
Thank you. I'm going to add, and let me know if this comes up in any of the other talks, and we can save it for them, but there is a question about using machine learning of EEG, but I think could also be expanded to any kind of able to provide individual basis of weaning anti-seizure medications and NORSE fires. So is there any sort of individualized, more precision-based approach?
I don't think we're there
I
yet.
think that's easy. No. Nobody's done that yet that I know of.
Yeah.
Yep. Another question from the chat. Again, let me know if, and we can always save some of these for some of the later talks too, but is monitoring of biomarkers useful in the chronic phase for defining the selection of the most appropriate therapy? If not, is it important to collect the level of these biomarkers for the development of new therapies and to be ready once they would be available?
I have a little bit of information in my talk on this. Broadly, I would like to say that most of the inflammatory biomarkers stabilize in post-acute phase. So monitoring them in post-acute phase is really doesn't provide too much information at this point. Perhaps we will discover some new, and there's some new sort of in the pipeline specific to brain injury, not so much to inflammatory state, but neuronal injury as a result of seizures. Those perhaps can be monitored in post-acute phase, but at this point we don't know how useful it is to guide our treatment decisions, especially in the recovery phase.
Yeah. Marius, you were unmuted for a second. Were you going to add anything, or do you want to save it for when you talk about immune?
Yeah, no, probably I will say it when I speak about
Okay.
it. That's fine.
Okay.
No worries.
All right, we have a few more questions. If other people in the audience have some, I think we talked about this one a little bit about balancing the risks of prolonged anesthetic exposure against the risk of seizure recurrence. Dr. Ribello walked us through kind of some of the timing of looking at when it's appropriate to begin tapering therapies rather than escalating, and that in the recent, shared in the recent patient that you had when you were in that point deciding whether to go up farther or to tolerate some seizures and come down. But anyone feel free to chime in if you want to add anything to these questions.
I can add one
Yeah.
quantitative piece to the Jim's prior answer about the highly
Yeah.
epileptiform burst. So we did that with Michael Fong in a more quantitative manner recently. And so highly epileptiform bursts are defined as 2 or more epileptiform discharges per burst, or if they're long bursts, at least 1 per second. And it turns out if you have that 2 or more per burst, there's a greater than 50% chance you're going to fail your attempted wean and you go back into status. So that 2 actually worked very well. If there was only 1, it was much lower. So that just gives you an idea, more than 50% chance you're going to fail wean if you have 2 or more spikes in most of your bursts. So, and that's been shown in at least 3 different groups now. So it is very useful for figuring out when you'd be able to come off your anesthetic.
Can I ask something, Larry? Because you said this number about 5%, which is actually probably what 3 minutes in an hour. And I know that because of the discussion we have in the clinical meetings, that actually it's not about the number; it's also about the type of the seizures and also how long the seizure is. Because someone may have tens of seizures of 10 seconds and have 3 minutes in an hour, but can have a generalized tonic-clonic convulsion that is 3 minutes or 5 minutes. It's a different thing. How did you come up with this number? I mean, is it something that you have, or it's just a personal preference? I'm saying that because
I'll show you shortly.
Shortly, okay.
Hold tight, huh? All right, we have a few more minutes before we'll get into some of the talks. So if anyone has other questions, feel free to put them in. I think the other one, and Mario says this is already in your talk, let me know, but when we looked at the treatment pathways, it talked about the different immune therapies that you can try. And I think a question that often comes up is, how many doses, how long to continue if you think it's helpful. So what is the approach to de-escalation or duration of treatment with immune therapies?
In my talk, actually, I say that there is absolutely no guide. The published literature about the length of timing for how long the duration of each immunotherapy is not correlating at all with outcome. So it's only you can see only what people are doing. So I've only given my personal opinion that once you start any of these therapies, then for different second-line therapies like anakinra, for example, you just commit to until discharge from the hospital or 3 months, whatever is less. And then tocilizumab, but say again, you commit to at least a month of treatment. I prefer weekly infusions and intrathecal dexamethasone. I say once you start to commit to five until if you feel effective, then you can continue maximum up to 8. But there's no guide. I don't think there's anyone who actually has any literature to support how long to go for.
Yeah, I think this is a great opportunity because you'll, share more about that in your talk, but for our other clinician panels members, do you guys have a similar approach, or how long do you continue immune therapy if it seemed to be helpful?
Yeah, I think that if the immune therapy is helpful, I think we've been treating for at least a couple of months, of course, looking at the seizure frequency and looking at the EEG. We tend to use an EEG as a biomarker for that, but also in part how the patient is doing from the point of view of their level of alertness.
Yeah, I don't know that we have a real standard protocol for this, but it's usually on the order of months. And yeah, we do use EEGs as a biomarker of how they're doing in addition to clinical reporting. But yeah, we really need more guidance. It's going to have to come from some biomarker probably.
Yeah, and I think it's important, for patients and families I think it's a question that comes up a lot in the chat, and we've seen in some of the family conferences in other years too about how long to continue. And so hopefully it's helpful to know that fortunately it's an area that we don't have as much data right now. And so, sounds like everyone's doing kind of a few months, but acknowledging that we don't have an exact answer for that yet. And I think this is we're getting towards the end of our questions, and you guys touched on this a little bit about seizures recur during de-escalation of therapy, what the approach is, and then the emergence of patterns along the ictal interictal continuum. And I think it depends kind of what we've talked about, what those patterns are and what the impact of them is. And then lastly, if you could give clinicians one practical take-home recommendation for safely de-escalating therapy in NORSE and FIRES, what would it be?
Sim, sim. Olha, fala da pediatria. Não? Eu pedi uma ecografia a uma menina, Margarida.
Ruben, I think you're muted. That's fine. I think Ruben is there.
I was able to mute him. Somebody must have made me co-host. Take home for me, one of the practical points is you can tolerate some seizure activity. I see a lot of places where, as they're taking off anesthetics, they see one seizure or a small seizure every hour, and they say, "Oh, they're having 20 seizures a day. We have to go back on." And so I know Marius was bothered that 5% was too low, but I think people sometimes overreact and treat every seizure and put them back on into coma. So I think tolerating some seizure activity is an important point when you're de-escalating.
Yeah, I would second that. Absolutely. I think, we did a paper years ago of a prolonged case. And, basically, if I remember right from that prolonged case, we tried 9 or 10 times to get the person off of infusions because when they had seizures, we put them back on. So, and I think in retrospect that was not the way to do it. So just as Larry says, I think it's very important. And when people say, or when people ask the question about families being involved in de-escalation, I think that's quite important for them for the families to understand that we have to tolerate we're going to have to tolerate a number of seizures. Now, how many we tolerate and how long we let that go, I'm not sure that there's an absolute answer to that. But I think up front, expectations are very important. So we involve families in those discussions and let them know that we think there will be ongoing seizures, especially with the younger patients.
Perfect. All right, thank you. I think that, oops. Oh, yeah, sorry. One more question. We have 2 minutes left. If anyone wants to say what they think the biggest challenge or controversy is, and where does expert practice differ most?
Everyone thinks they're an expert. So that makes it difficult when you have teams of people. And I think so we need to have sort of set ideas or set goals or guidelines as to how we do that. So I think that that's the biggest controversy is you'll get different opinions depending on who the doctor is.
I would echo that and say that we need centers of excellence for treatment of NORSE, not only acute, but also chronic management, where there will be a collection of expertise, multidisciplinary expertise that sort of think in the same way, maybe, and were trained in the same way, have the same level of experience and comfort in managing those patients. So I think that's in the future, and we're working on this.
Yeah, Marius.
Yeah, in my experience, there's two main issues that are still, I think, very puzzling. One, in terms of de-escalation of treatment, which has to do with the escalation of treatment as well. One is the length of the PER suppression or suppression of the EEG that different centers around the world are using. And there's different school of thoughts. And I think at least in North America, Europe, we are probably more conservative than other countries. For example, Japan and all this, where PER suppression can be for several days or months sometimes. And the second one is in terms of the immunotherapy, as we're going to see also from at least my again experiences, there's different models of care that are based on very little evidence, and then it's very difficult to move. And that's why these meetings are very important. The collaboration and talking among the clinicians, actually, starting from the point that actually we all understand that actually the evidence is very little.
Mm-hmm. All right. Thank you. Let me Yeah, so now we'll talk more about acute management with Dr. Hirsch. So let me stop sharing. And we will switch over. And thank you again to all of our clinicians for answering some tough questions where we don't have a lot of data.
Am I sharing the proper
Yes. Yep.
version? Okay, I'm just trying to hide my controls here. All right, so I'm going to talk about some of the things we already talked about, acute management. And seizure burden in number particularly is what I was asked to talk about. Okay, disclosures. So one of the big questions is about the harms of non-convulsive seizures and non-convulsive status and why we care about it and what the evidence is. So there have been extensive studies showing that the adverse effects of non-convulsive seizures include all these things that can hurt the brain, particularly in the acute setting where it's under stress. So increased blood flow, intracranial pressure, glutamate, which is an excitatory neurotransmitter that is toxic to brain cells at the levels that have been shown to happen with non-convulsive status. Membranes break down, you get increased swelling in the brain, and a few other things. There's been a lot of nice studies looking at medium and long-term effects, not just those acute physiologic effects from non-convulsive status. This is not specific to NORSE, but it's just non-convulsive status in general. So after intracerebral hemorrhage, you get increased mass effect. In trauma, you get hippocampal atrophy if you had non-convulsive status compared to the same injury without the non-convulsive status. And looking at longer-term outcome in children, studies showed you get worse functional outcome, quality of life, and new onset epilepsy after electrographic status, and with very high numbers in the rate of developing new epilepsy, as I think all of you are aware. And then in adults, there's been studies and now in several different etiologies showing worse neurologic function as well, with a real dose response related to the amount of non-convulsive seizure activity that you have. So this is one of those studies with a very large cohort of 400 adults with subarachnoid hemorrhage and looked at the number of hours of seizures on the x-axis here. And then this is your cognitive score, showing the more hours of seizures you had in total during your acute hospitalization, how your cognition did later. And this is many months out where the cognition was measured. And same with unfavorable functional outcome in the long term. The hours of non-convulsive seizures was pretty directly related to that. Then I did want to mention, you mentioned the ictal interictal continuum, so that includes things like periodic discharges that are happening 1 or 2 times every second, these spikes that just keep going, so your brain looks almost like an EKG instead of an EEG. So these actually are harmful for the brain at times, particularly when they're faster and particularly when the brain is under stress. So this was a study in subarachnoid hemorrhage patients and showed that, I think it's easier in the graph here, as the frequency per second of these discharges increased, your brain tissue oxygen, this was measured invasively with a probe in the brain. Once you get 2 per second or faster, it can't keep up with delivering enough oxygen, and you get secondary neuronal injury from that. So they concluded that the brain could compensate up to about 2 per second, but not faster than that. Other studies have shown that these periodic discharges cause a dramatic increase in brain metabolism. So this study used PET scans and showed if you have one hertz, that's a 100% increase in your brain metabolism. And if you have more than 1 hertz, it was a tripling. So they take you need a large glucose and oxygen supply to avoid getting neuronal injury from those periodic discharges. And then using some fancy automated detection with AI algorithms for looking for these highly epileptiform patterns in people with acute brain injury. Again, this isn't just NORSE, it's all acute brain injury. And this was 2,000 patients, and they have software that can pick up these patterns. It can't necessarily separate out seizures from the periodic discharges, and the vast majority of these are not seizures. They're the ictal and rictal continuum. But they found the best predictor of outcome in this very large cohort was the peak 12-hour epileptiform burden. And it had lots of zeros in the p-value, and it was a clear dose-dependent manner. And this is from that paper. It shows 4 different subgroups, and in all of them, the maximum 12-hour seizure burden, that's what's on the x-axis, was correlated with outcomes. So probability of poor outcomes on the y-axis. So this first one is acute brain injury. This next one is cardiac arrest. And then here is acute seizures or status without any known acute brain injury. So this would include all the NORSE patients, and there were 279 in this cohort. And you see that was actually the one, there's just very clear relationship between the peak 12-hour burden of these epileptiform patterns, again, they're mostly not seizures, just highly epileptiform patterns, and the probability of poor outcome. Okay, and then Marios asked about where that 5% came from. It actually came from this paper. So this is from the Brandon Westover's group. But they looked at, this is in critically ill patients, so another huge cohort, and looked at the maximum epileptiform activity or the average epileptiform activity over a longer time point. And looking at the maximum 6 hours in this particular one, they found it had to be pretty high, really 50% or higher to show a clear correlation with higher risk of poor outcome. But if you look at longer period over 24 hours, here's the group that was 2 to 10% epileptiform activity burden. So again, mostly not seizures, but these highly epileptiform patterns. That was a statistically significant independent association with worse outcome in that study. So it looked like the 2 to 10% was enough to get you with the independent association with worse outcome. So they concluded that short bursts of high burden of epileptiform activity was bad for the brain, and long runs of a low to medium burden, even 2 to 10% over 24 hours, had an adverse effect. And again, this is not specific to NORSE, but included NORSE patients. Just in a very quick tour of some other papers looking at seizure burden and status duration, those kinds of things. This was a paper on quality of life over time after NORSE from our biobank. And it showed longer status duration and longer ICU stay were independently associated with worse long-term quality of life. A very recent paper came out of Mount Sinai, led this one. They looked at acute EEG findings, and this was based on 44 patients from our biorepository who had detailed daily EEG findings, which we tried to do in our prospective multi-center study. And it had to have a minimum of 4 days of recording for this so they could look at seizure burden. 61% of these patients had seizures after hospital discharge, and the predictors of post-discharge seizures, which is really how we define post-NORSE epilepsy, if you have any unprovoked seizures after discharge. And you see seizure burden there was a predictor of having epilepsy after, as was the proportion of the video EEG days that had seizures. They also noticed the pattern where the majority of patients had convulsions or obvious clinical seizures when they presented, so those 2/3 of the cases. But note that means 1/3 did not, so 1/3 actually presented with non-convulsive seizures. But virtually all the patients turned into non-convulsive seizures and non-convulsive status. There's another attempt to look at this that Nicholas Gaspard led with 48 patients that were really highly, thoroughly characterized, and they did not find any clear independent predictors of outcome from the acute presentation or the acute treatments. Multiple other studies have shown an association between use of prolonged anesthetics or more anti-seizure medications, and Professor Von Ballen discussed those 2 days ago, and worse outcomes. But I like to reword that into it's patients who need prolonged anesthetics and need more ASMs who are the ones who have worse outcomes. So I don't think there's any convincing evidence that those themselves are causing it. It's so confounded by the severity of the initial illness. But that's very difficult to tease out. The only real way to do it is with a prospective randomized trial. Okay, the last study I'll mention is work in progress that's going to be presented soon at the International Congress on Clinical Neurophysiology in Cartagena. But for this one, Daniel Bo and Humberto Moserfilo are leading this. We looked at 125 patients in the biorepository that had 1-year outcome available, and we defined good outcome as a GAS-E score of 5 or higher, which is really being independent, at least in your daily living, and very good outcome, meaning a 7 or 8, which is as good as you can do. And results were that the status epilepticus duration was highly correlated with outcome in a nonlinear fashion. I'll show you a graph in a minute about that. Just for people who don't know that outcome scale, this is it. It goes from 1 to 8. So the moderate disability is the 5 and 6s, and good recovery are the 7 and 8. So that's the scale we're using. And this is a graph that summarizes the data from this. So it's the status epilepticus duration and your outcome score on the chance of having a good outcome in this particular graph. So you can see once there's a pretty precipitous drop as you go from more than a week of refractory status. And you see little numbers up here. If it goes for 10 days or more, there's a 31% chance of good outcome at 12 months. Whereas if it goes more than a month, you still have 26% chance of good outcome. So it actually plateaus between 10 days and a month. And then it starts to drop again, where if it gets longer, your chances of good outcome are significantly lower. And now looking at the same thing, but this time looking at very good outcome. So this is a 7 or 8. Similar cutoff, somewhere around 7 to 10 days seems to plateau. If you're greater than 1 month, there's a 9% chance of a very good outcome. I do want to point out that if you look at the trajectory over time, after 12 months, you can see, so what this shows is outcome compared to your 3 to 6 months actually. But starting with that outcome, the chance of whether you're going to continue to improve or not. So the ones in blue go up, that's an improvement in their outcome score. And this is at 12 months, 24 months, and 5 years. So you see many people continue to improve, all these blue ones, even after 12 months. So it's not that 12 months is necessarily the final outcome, but it's a good measure. Lastly, I will point out in our upcoming Combat NORSE trial, we will be including daily seizure burdens, and we will be keeping careful track of all the treatments given. So hopefully we will get a lot more answers. And then in a separately funded method, we're going to still be looking at all the biomarkers and things that everybody's so interested in. And I wanted to show off our new logo, thanks to Maggie Gopal and Nora Wong for developing that. So take-home message is seizure burden and the burden of highly epileptiform patterns are important and correlate with outcomes seemingly independent in many populations, although there aren't any large trials in NORSE to look at that specifically. There's always a tricky balance between how aggressive to treat and how much seizure activity to tolerate, as we talked about. And when reporting outcome, I do like to stress that it's not just survival, it's crucial to be looking at brain function. That's what we're trying to save, is brain cells and their function. So you have to look at cognition, behavior, mood, and later epilepsy as well, and preferably as long-term as you can. And with that, I will stop. Thank you.
Thank you. We'll go on to Dr. Tereshenko in just a minute. I just have one follow-up question I want to ask you about the data that you shared at the end. For the ones who had no improvement, improved, or declined, were you guys able to look at if there's any predictors at which group they would fall into in terms of that long-term GASI scale and the trajectory of it over time?
I think the short answer is not yet. But we really don't have enough patients who have 5 years of follow-up to be able to have reasonable number. So we have a lot. We have well over 100 at 1 year now, but it's going to take a little time to get the 2 and 5 year outcomes.
Okay. All right. Thank you. We'll go on to Dr. Terashenko next. And if people have, again, questions, you can put them in the chat and we'll try and answer them in there as well.
All right. Hello, everyone, again. Can you see my slides?
Yes.
Okay, perfect. So I was asked to talk about chronic management and particularly about the development of epilepsy and how seizure burden and number of seizures after the discharge affect quality of life. So I have no relevant disclosures. Um, the data on seizures after acute phase of NORSE is available widely, and we just know that a lot of people, over 50%, will develop epilepsy on discharge. Unfortunately, those seizures will be multifocal, which means they're coming from multiple areas of the brain, which puts additional challenge in managing them, because rarely do we have a resectable target, and doing resective surgery is hardly an option in those patients. And they do fall into a drug-resistant epilepsy category, which means they fail 2 or more anti-seizure medications, by default. Even in post-acute state, many of them are on multiple anti-seizure medications. And we know that those rates of drug-resistant patients is about 40% in adults, and unfortunately higher in children. More than 57% of children will suffer from drug-resistant epilepsy. Seizure freedom is rare. About 26% of adult and 23% of kids may become seizure free on multiple anti-seizure medications and perhaps oftentimes on immunotherapy. So this is just a summary of several papers that were reviewed recently, relatively recently. In our systematic review, we use a 30-day cutoff as a definition of sort of post-acute NORSE. And it turns out that it doesn't matter where the patient was treated. So we, in the previous slide, we surveyed available literature from sort of all over the world, different sizes of the hospitals and patient population. This is the data from our NORSE biorepository, something that Dr. Hirsch mentioned in his talk. And those patients typically are treated at large academic centers who contribute to the biorepository, and turns out that the data looks about the same. So 61% of NORSE patients will continue to have seizures in a chronic phase with a median of 15 months. As I mentioned, they are oftentimes on multiple anti-seizure medications. The median number of those medications is 4, but I personally treated patients who were on 7 medications, including the first generation, which have a lot of side effects. The predictors of epilepsy, and that's again looking at their inpatient stay. So patients with electroclinical seizures, higher seizure burden, again, not necessarily, um, you know, um, number of seizures, but also more prolonged seizures, and then proportion of days with seizures were reliable predictors of developing chronic epilepsy in NORSE. Now, yesterday there were many talks about cryptogenic NORSE, and this is a particularly sort of challenging category of patients for us, where the etiology or the cause of a NORSE is unknown. So those patients do even worse in a chronic state. Over 70% of them will go on to develop epilepsy. And in those patients specifically, the predictors of chronic seizures will be diagnosis of fires. So 79 with fires versus 38 without fires, as well as longer duration of status epilepticus. You can see a drastic difference here for 34 versus 9 days. ICU stay is a reliable predictor of chronic epilepsy. Somebody asked during the question session whether any inflammatory markers could be used to guide the treatment decisions or management in post-acute phase, and unfortunately many of them quiet down, or maybe fortunately for patients, but unfortunate for us because we gain some knowledge about the markers and their usefulness in an acute state, and they do seem to have no value in our treatment decisions because that's been confirmed in a recent papers that there were no acute serum or CSF biomarkers that would predict chronic epilepsy in cryptogenic NORSE. When we talk about principles of chronic management, we have to balance multiple arms. For example, we need to think about anti-seizure medication optimization, what I would do with immunotherapy, when to discontinue or transition ketogenic diet, which is gaining popularity among the adult patients with NORSE, and then how all of this will affect rehabilitation and recovery, including cognitive recovery and quality of life. Um, well, when we talk about medication management strategies, they are all over the place for the chronic NORSE. The data are insufficient, and we usually apply the same principles that we apply to treatment of other severe drug-resistant epilepsy syndromes. For example, we think of rational polytherapy, which is aimed to enhance synergy and reduce toxicity and side effects. One example of combinations that we like is lamotrigine with valproate. There are some other combinations, for example, Epidiolex and clobazam, etc. There was an emergence of third generation of anti-seizure medications, which are quite potent and quite effective. And cenobamide was mentioned today, and it's been really a wonderful agent that help a lot of our patients, not only with NORSE but other bad refractory forms of epilepsy, to be transitioned out of first generation agents. And this is also true for the NORSE patients, and cenobamide sometimes allows us to transition patients out of phenobarbital and other agents with a lot of side effects. And so there are a couple other newer ACMs that seem to be very helpful. Immunotherapy will be talked about in subsequent talks, but again, we only report here in the slide what we found in the literature. This is not recommended, or this recommended duration, but what is reported in the literature that immunotherapy was maintained for about from a few months to 1 year post acute onset of seizures in NORSE. There was a paper, sort of small case series here on 5 pediatric FIRES patients, where the median duration of anakinra was 9 months, and then at 6 months there was 100% of patients who continued this. However, at 12 months, more than half of them dropped out because they believed that the agent was ineffective, not so much for the side effects, but for ineffectiveness. And this is percent seizure reduction in those patients. You can see that at least 30%, but many of them had as high as 45 or 50, close to 50% seizure reduction. Anakinra or tocilizumab started during an acute status epilepticus did not affect the development of post-NORSE epilepsy. So while these agents are very helpful in an acute state, those who receive or did not receive those immunotherapies during an acute phase still develop post-NORSE epilepsy, and there was no difference in those cohorts. There were some reports that later institution of immunotherapy, particularly anakinra, decreased seizure burden in a small cohort of patients. And then another small case series of 2 patients where intrathecal dexamethasone and chronic anakinra reduced seizures and achieved seizure freedom in 2 patients who were treated up to 200 days from the acute onset of seizures. Ketogenic diet, we are just gaining more data. We are very optimistic that the usage of ketogenic diet has increased since the consensus publication in 2022. And you can see the difference here. The odds ratio is 6.8 for early years, for later years versus earlier. And this therapy is used nowadays more frequently in adults than it was before. And the data, when it comes to specifically patients with NORSE, is very limited in terms of what happens in the chronic phase. We do know that in a large trial on refractory status epilepticus, in which also 5 NORSE patients were included. About 50% of those patients with NORSE were transitioned to modified Atkins diet on discharge, and actually as soon as they were able to have oral intake, because modified Atkins diet is more easy to maintain and has less restrictions in terms of not only food, but also what medications can be used and their sugar content. Again, this is just a broad philosophical questions. For us, it's an art really. Until we are replaced by robots, I don't think we'll have absolutely unified decision, but we need more evidence. It's not there yet. When do we revisit the treatments and de-escalate? So for anti-seizure medications, as clinically indicated, we rely on the family reports, rely on the reports from this physiatrist if the patients are in the rehab, in terms of how well they're doing, participating in rehab, and side effects. For immunotherapy, it's unclear, but at least 6 to 12 months before we can decide to wean those agents off. And for ketogenic diet, it seems to be the tendency to transition patients out on discharge or even sooner whenever the oral intake is possible. So briefly, how the quality
Olga, I'm going to say one minute if you can.
Yes, I only have 2 more slides. How the quality of life relate to seizures? We know that seizure freedom was the single most important determinant of better quality of life in NORSE survivals. And it's important that quality of life improved in parallel with seizure reduction. So the most significant improvement happened in the first year and less change subsequently. Longer status duration and ICU stay were directly associated with worse quality of life, and higher number of medications associated with more depression, cognitive impairment, and perceived stigma, which worsens quality of life. So there were major 4 themes in which seizure burden impacts quality of life. Side effect of medications were one of the most significant contributors, and I'm sure you're familiar with this list. So anything from drowsiness to increased suicidal ideations. And then other themes were mental health, relationship changes affecting social and emotional well-being, and finally, caregiver burden. And with that, in summary, management of seizures in post-acute NORSE includes ACM and immunotherapy reduction, very careful, high seizure burden, medication side effects of loss of independence results in poor quality of life. And that definitely needs a multidisciplinary approach involving epileptologists, physiatrists, and psychiatrists, which would be critical for successful rehabilitation. And I'll stop there. Thank you.
Thank you so much. There's a couple of questions in the chat that maybe, Olga, you can answer in the chat, and then we'll let our family panel of speakers start. I'm just going to share my screen again.
Okay.
I click, and then...
one of the questions, as someone whose child currently in the subacute phase, still in the ICU, what would be the biggest question you would recommend as a family ask of our providers as we transition to the chronic phase? Yes, I'm sorry that you're dealing with this. This is very hard. Well, I think you you need to have a good transition of care. I think it's important that you will remain at the center that has expertise in management this condition chronically, so that you have access to multidisciplinary team. So if you live far away, ask to be referred and being established with all those specialists who are participating in care of your child now. Those are physical therapists, perhaps psychiatry was involved, perhaps GI was involved. So I think this would be the most useful suggestions, that you stay where the expertise is for chronic care.
Thank you. The other question, I'm just going to have you type your answer into the chat, and we'll let our family panel start sharing.
Thank you.
And Jean, do you want to go first?
Hello, everyone. Good noon. I'm very happy to join that meeting. I'm from Turkey. First of all, I would like to thank you for giving me the opportunity to share my daughter Nehir's story with you. Nehir was a completely healthy child until October 2024, when she suddenly developed fires. From that day on, our lives changed completely, as you know. Despite extensive investigation for infectious, autoimmune, metabolic, genetic, or other possible causes, no definite cause was ever identified. During the acute phase, every recommended treatment was attempted. She received multiple anti-seizure medications, prolonged anesthetic therapy, intravenous EWIC, high-dose steroids, immune therapies, including anakinra, tocilizumab, and cyclophosphamide. Even also broad-spectrum antibacterial and antiviral therapies, as well as other supportive treatments. Unfortunately, despite all these interventions, her seizures couldn't be controlled. Then on February 11, 2025, everything changed. Nehir suffered a cardiac arrest that lasts approximately 20 minutes. After successful resuscitation, her first EEG showed a complete flat line. She had no signs of conscience, no spontaneous movements, and was completely dependent on mechanical ventilation. Unexpectedly, from that moment onward, her seizures completely stopped. We still do not know why. Perhaps the brain regions responsible for generating seizures were damaged by lack of oxygen, or perhaps another mechanism interrupted the abnormal electric activity in her brain. We simply don't know the cause of it. At that time, many physicians believed she would never leave the intensive care unit and would remain dependent on respiratory support. Instead of giving up, we took another difficult path. Although Nair showed no meaningful response, we immediately started an intensive rehabilitation program. She received physical therapy 5 times every day, with each session lasting at least 30 minutes. About 1 month later, she opened her eyes for the first time. She developed cortical blindness, most likely as a consequence of the prolonged occipital seizures during the acute phase of fires. Although she still cannot see, she developed a normal sleep-wake cycle. During the day, her eyes remained open, and at night she slept with her eyes closed. That was our first encouraging sign. We continued rehabilitation without interruption. Initially, she had no swallowing function at all. We began swallowing rehabilitation, and although there was no immediate improvement, we gradually started seeing progress. Electromyography had shown severe damage at that time, affecting almost all muscles and nerves. Over time, we observed recovery, first in her arms and later in her legs. Her swallowing also improved, although it is still not where we would like it to be. Today, Nehir responds to sounds and touch. She had become much more aware of her surroundings. Even light touch produce clear response. Her dystonia has improved significantly and she's gradually regaining head control, which we believe is essential for further improving her swallowing ability. Alongside rehabilitation, we have tried to optimize every aspect of supportive care. She received nutritional support, including high-dose DHA from fish oil, 3,000 milligram, I think, magnesium lethionate. That kind of magnesium crossed the blood-brain barrier. Phospholipid supplementation, the mark of it, body bio. Zinc, vitamin D, liposomal vitamin C, liposomal glutathione, carnitine, and coenzyme. We carefully monitor her nutrition and blood tests, maintain adequate vitamin D levels, keep it from 60 and 80, and try to optimize her protein and albumin levels through nutrition. Although we cannot scientifically prove that these supplements are responsible for recovery, we believe they have supported her rehabilitation based on our clinical observations. We have also cautiously explored treatments aimed at improving consciousness. Both zolpidem and citicoline appeared to increase her awareness of the environment, but they also caused agitation. So we now use them only cautiously and intermittently. We also tried vagus nerve stimulation. Although it occasionally seemed to improve swallowing during stimulation, overall it reduced muscle tone and actually made swallowing more difficult. So we decided not to continue using it. Another major challenge has been episodes of proximal sympathetic hyperactivity or PSH. Fortunately, these episodes have become much less frequent over time. Interestingly, during sympathetic activation, her swallowing is actually better than when she becomes very relaxed. And gabapentin has helped reduce both her dystonia and PSH episodes. We also noticed that after starting magnesium lethionate, her myoclonic jerks become much less frequent. Although we cannot prove a direct causal relationship, this has been our clinical observation. Because Nair has a shunt, we have been cautious about introducing more experimental therapies. Instead, we decided to focus on intensive rehabilitation and supportive care. Today, she spends 1 hour sitting, 1 hour standing frame, approximately 2 hours receiving physical therapy, and 1 hour receiving swallowing rehabilitation every single day. We also strongly believe in environmental enrichment. We maintain a structured daily routine, perform regular smell therapy, encourage a healthy sleep-wake routine with prolonged release melatonin, and take her outside every day so she can experience natural daylight, fresh air, and environmental stimulation. Our primary goal is simple. If we can further improve her swallowing and head control, we hope to mobilize her safely in a wheelchair and allow her to interact even more with the world around her. Our journey is far from over. After 20 minutes of cardiac arrest, we had to begin recovery from an extremely severe brain injury. But our experience has taught us one very important lesson. Treatment does not end when the seizure stops. For many children with FIRES, rehabilitation becomes just as important as seizure controls. Even after devastating neurological injury, recovery is still possible. Intensive rehabilitation, swallowing therapy, good nutrition, environmental stimulation, and patient constant and daily care may not produce dramatic change overnight, but together they can create meaningful progress. Recovery is not measured only by major milestones. It is built from many small victories that accumulate over time. We sincerely hope that continued research will help us better understand FIRES and NORSE and provide better treatment for children like Nehir. Thank you very much for your listening.
Thank you for sharing and really highlighting some key takeaways about the experience and all that goes into the ongoing, after that, the ICU phase and everything. Tara, I think I have you next.
Hi, good morning. I appreciate being here today. I'm going to touch on a few things that helped me with my son and a few things that I learned and feel that doctors should help with the families and the medical staff. My name's Tara, and my 17-year-old son Matthew fell ill on 12/17 of 22, 3 months into his senior year of high school. After a week-long up and down fever, he had just driven himself to the doctor the day before, and they found nothing wrong with him, but just a low-grade fever. I found him cold, seizing, and blue on the morning of the 17th. He was rushed to Seattle Children's Hospital, and our nightmare began, and my son's life changed forever. He would never be the same due to the damage to his brain and the seizures he would eventually endure. I read this like 9 times yesterday and didn't cry. Admitted to the ICU in critical condition and continually rolling seizures, Matthew was hospitalized for 14 months, 4 of those in the ICU. He could not talk, walk, eat, stand, self-care, and was wheelchair-bound. We never knew if he understood what happened to him or if he remembered anything about his life pre-onset. He was discharged to an adult family home 25 minutes away from me with 24-hour care to maintain his continual seizures and his complex medications, never going more than 19 days ever seizure-free. Matthew would smile, laugh, wink, clap, cry, and scooter his wheelchair around for almost 2 years. Understanding the seizure burden. One of the most important concepts I wish someone would have explained to me in the early days was seizure burden. I did not fully understand or hear this term until weeks after my son's diagnosis. Families need a clear explanation of what doctors mean when they discuss seizure burden and how it relates to their child's medical condition. Are they referring to the number of seizures, the duration of the seizures, the type of seizure activity, or all of them? Our goal was to reduce both the frequency of seizures and the overall burden they place on my son's body by finding the right medications that are effective. Having this explained from the beginning would have helped me better understand my son's treatment plan and the goals of his medical team. Having a seizure journal. I wish someone would have told me from the beginning to keep detailed notes of his seizures, tracking every seizure, its start time, its duration, its characteristics, and recovery became one of the most valuable tools in my son's care. It is equally important to understand the difference between the actual seizures and the postdictal phases. I repeatedly asked my son's epileptologist, who is on this call today, Dr. Carlos Castillo-Pinto, how to accurately time his seizures and made sure every person caring for him knew exactly how to do the same. No one initially instructed me to keep these records or suggested using an app to document his seizure activity. Medical teams should clearly explain the difference between seizure activity and postdictal stages, so families and caregivers can accurately document seizure duration. This is critical because incorrect timing can lead to unnecessary rescue medications. During Matthew's 14-month-long stay, I observed multiple nurses documenting the wrong seizure length because they included the postdictal phase. I had to teach them what to watch for when the seizure was actually over and how to distinguish it from the recovery period. Repeating this lesson daily was emotionally and physically exhausting. Better education for both the families and the healthcare providers could prevent misunderstandings and improve patient care. What helped me the most was one of the greatest sources of support was being allowed to stay with my son through his entire 14-month stay at Children's Hospital in Seattle, from the ICU phase through the medical floor. Having this accommodation allowed me to be present at bedside 24 hours a day and participate in everything having to do with my son, with morning and evening rounds. My son could not speak for himself, so I became his voice. I will always be grateful for the compassion, accessibility, and partnership of the entire Seattle Children's Hospital team, and especially Dr. Carlos Castillo-Pinto. He was available even during the most difficult nights. I could email him at any hour when I was worried about my son, and he constantly responded, often before he even had his morning coffee. I valued honest, direct communication with my son's physicians and made it very clear I wanted the truth, no matter how difficult, so I could make the best decisions for his care. I worked closely with the neurology team, including Dr. Pinto and Dr. Wainwright, and we discussed eventually an RNS, a responsive neurostimulation device, to help control Matthew's seizures. I asked whether it would improve my son's cognitive function, and Dr. Pinto answered honestly that it was unlikely to improve and my son had most likely reached his new baseline. That conversation guided one of the hardest decisions I made, was not to proceed with the surgery because I didn't want to put my son through any painful procedure when he could not tell me that he was hurting. After a gradual decline beginning in the fall of 2025, Matthew passed away on November 14th, 2025. So 8 months tomorrow, at the age of 20. He lived with NORSE virus for 1,063 days, having about 2,000 seizures during his journey. Continuity of care was essential for our family. Having the same physicians who understood my son's complex medical history, seizure patterns, medication responses made an enormous difference. I only recently learned about the concept of Centers for Excellence for NORSE virus. Access to a team of specialists experienced with the rare condition would have been invaluable and could have spared families the added burden of transferring between hospitals in the search of knowledgeable care. Our specialists at Seattle Children's Hospital cared for my son from diagnosis until his death. They knew his history. They remained committed to his care through his journey, and continually this continuity should be the standard wherever possible for families facing such complex conditions. Thank you.
Thank you, Tara, for sharing and highlighting so many key points, and I'm sorry for your loss as well. All right, Rachel.
Thank you. I'm not too sure. I'm going to follow on from those two stories. That was so emotional. So I'm Rachel Liu. I'm Sam's mum. I'm from the UK, and my son Sam was struck down by fires in 2021. He was just 5 years old. He died 7 weeks later from catastrophic brain damage. My understanding of seizure burden from a parent's perspective has evolved over the past 5 years. If you'd asked me in 2021 what seizure burden meant, my answer would have been simple. It meant one thing: the number of seizures Sam was having and the damage those seizures could be doing to his brain. The term seizure burden was never fully explained, and 5 years on, I now realise Sam's seizure burden was far more complex than I ever understood at the time. Even in the rare moments when Sam wasn't having seizures, in my layman's terms, his background EEG remained profoundly abnormal. No one seemed to be able to understand his brain patterns outside of his seizures and over the 7 weeks, and what this meant for Sam at that moment, or what it meant for his future. Within just 7 days of the onset of his fires, Sam developed brain swelling and lost his pupil reflexes. His pupil reflexes never came back, and over the weeks that followed, we watched him sustain devastating brain injury that ultimately became catastrophic. And I do wonder what Sam's seizure burden was telling us even early on about the devastating trajectory he was on. And one aspect I don't hear talked about very often is the profound weight loss. Sam became skin and bone, and the emotional impact of watching your child lose so much weight is just utterly horrific. As the weeks went on, Sam's seizure burden caused more and more physical complications, such as cerebral salt wasting. He could no longer retain fluids properly. His triglyceride levels became so dangerously high. His parental nutrition had to be stopped. He developed infections, persistently high temperatures, and his heart rhythm and blood pressure became increasingly unstable. And then there was a constant suctioning. After Sam's anaesthetics were withdrawn, he needed almost constant suctioning to keep his airway clear. And it was for the first time we worried that he might be able to feel pain. Looking back, I don't know where seizure burden ended and the burden of fires, critical illness and treatment began. But what I do know is that we weren't just watching seizures anymore. We were literally watching our child physically disappear in front of us. I was so focused on stopping the seizures that I wasn't seeing the enormous physical burden this disease, the relentless seizures and the treatments together were placing on his whole body. And the emotional burden is huge from watching your child or loved one continually seize, having no answers, watching treatments fail and living with constant uncertainty. And for almost 7 weeks, we've been able to do the most natural thing in the world as parents, to hold his hand, stroke his face or comfort him, because we were told even the smallest touch might trigger another seizure. Trying to be an active member of the clinical team whilst keeping your emotions in check when all you really want to do is scream, "Please make my child better," is incredibly difficult. There's also the emotional burden of having to place absolute trust in the clinical team caring for your child or loved one. In intensive care, that often means placing your child's trust in the hands of consultants and nurses you've only just met. And finally, the burden of treatment. While I was focused entirely on Sam's seizures and stopping them, the clinical team were having to balance his seizure burden against the risks of prolonged anaesthesia, multiple anti-seizure medications, and the risks of intensive care itself. Whenever clinicians discussed changing his medications or reducing his anaesthetics, I became frightened. I worried that changing treatment would mean more seizures, more brain damage, and that perhaps I were giving up on my son. But the clinical team are continually balancing the risks of ongoing seizures against the risk of increasingly intensive treatments and medications and the impacts of them. So back in 2021, I thought seizure burden was simply about the number of seizures Sam was having. And 5 years on, I understand it means so much more. Thank you.
Thank you, Rachel, and thank you all again for sharing and some really emotional and very personal experiences, and I think still highlighting such important key takeaways for us as clinicians as well. Nora, do you want to say anything before we go into our break?
No, I think we should go on break, and thank you.
Yeah.
Thank you, Angan, and Tara, and Rachel.
Okay. We will just do a quick 3-minute break and then start back up at 12:40 to start our next talks. And if anyone needs a little bit more time, just join back when you can, but we'll make it a little bit shorter so that we can get through the rest of our talks. Thank you, everyone. Okay. All right, thank you, everyone. I know, sorry, we didn't too much time for a break there, but we'll move on to our next talk, which I think is, Marios.
Great. Can you hear me well? I just want to know if I need to hold my microphone like this or if I can get away like this. Can you hear me well now?
Probably a little bit better like this.
Okay. Okay. I'll hold it like.
Sorry about that.
Like Shakira. Okay. Just give me a moment to share the screen. Can you see the full presentation now?
Yes.
Yep. Perfect.
Okay, great. Okay, so I was asked to talk about immunotherapy for how long and if there's any evidence on when to restart, or to restart. I just put there the comment by Charles Scott, the previous Guardian editor, who said actually comment is free, but facts are sacred. And actually, I could stop the talk right now because actually there's very little facts to support whatever I'm going to say. So whatever you're going to hear is probably going to be at best an informed opinion, but still an opinion. I want to just acknowledge Dr. Aurelie Hanin because she shared her curated literature database with us, and then Dr. Rafael Mitakidou, who is a fellow in our department. Because I was away on holiday, she actually mined the data for me from this database that Aurelie shared. So I'm very grateful to her as well. I have no disclosures, and this is the overview of my talk. Actually, I will just speak a little bit about first principles and sense making, and then models of treatment as I conceptualize them through the experience I have so far, and then how little evidence there is out there and what the future may hold. And when I speak about first principles, what I want to say is, first of all, is the misconception of what Hippocrates had said and how this turned out in the mid-18th century to be completely wrongly translated. Actually, he never said first do no harm. Actually, what he said is that the physician must always have two special objects in view with regard to disease, namely to do good or to do no harm. And this is very important because a lot of the treatments, especially immunotherapies and anesthetics that we use in these patients, can be harmful. But on the other hand, we have to always remember that these patients are in extremis, and we have to have less fear to choose these treatments. I would say actually the most important question in FIRE's NORSE is not so much about the escalation of treatment, but actually to take away the fear from the clinicians to be escalating the treatment and to have an approach that says all guns blazing, which is completely counterintuitive to what we usually do in medicine, which is actually a stepwise approach of escalation of treatments. The other thing to remember is the evidence is very poor, and be aware of the publication bias. This means that actually people publish, and researchers and clinicians publish always their best results, and this can actually lead to very skewed appreciation of which treatments can be effective or not. And also remember that consensus is built on expert agreement, but on the other hand, you have always to be very aware of expert agreement can always sometimes lead to group thinking and echo chamber phenomena. So I just wanted also to remind the phrase from the quote from Upton Sinclair, who said it's difficult to get a man to understand something, especially when his salary depends upon his not understanding it. And here you can actually substitute salary in this context with either egos or scientific gravitas or invested projects, etc. What I'm trying to say is we always have to be transparent, open-minded, and sincere about the lack of evidence. So the different models of treatment, as we have seen them from all the experience through the years, especially also through the International Clinical Fires meeting the last 2 years, but also through review of papers, is that in North America and Europe, and I'm going to be talking only about second-line immunotherapy, second and third-line immunotherapy. So in North America and Europe, the second-line therapy usually is anakinra first, and then people are switching to tocilizumab, usually after 2 to 3 weeks of good dose of anakinra if felt ineffective. For historical reasons, and because anakinra was first reported in a case report, and that's where the anakinra story started, from the Eric Payne publishing that case report from the Mayo Clinic with the anakinra response. The pediatrics have taken more up the anakinra, while the adults, with a South Korean paper that came up in 2018, publishing tocilizumab in the NORSE, they have taken up usually mostly tocilizumab. So some adult centers may start mostly with tocilizumab. The other thing that came up was actually from Japan, the use of, from Hiroshi Sakuma's group, the use of intrathecal dexamethasone, which is actually has been taken up now very much from European and North American centers. And most often now we advocate for very early initiation concurrently with anakinra or tocilizumab. Chinese groups have an interesting approach, at least in Beijing, as much as we know, and these papers probably will come out soon, is that they use actually tocilizumab first, and then interestingly, they use anakinra as add-on. So that means they don't stop tocilizumab, they go on with tocilizumab and they add on anakinra. In Malaysia, we had recently presentation from the pediatric neurology colleague Sumita there, where for children, where they use tocilizumab only, and because they don't have access to anakinra. It was very interesting to hear her presentation in the clinical meeting the other day. And in South Korea, again, for adult patients, the group that I'm going to show a little bit about their paper, they actually use rituximab, which seems as a first line, and then they use tocilizumab possibly as an add-on, although it's not very clear from the data I have seen from their paper if it's an add-on or actually if they just move on to tocilizumab, but they just use 2 doses of rituximab. Now, this is the curated database, literature database that Aurelie has created and her team. It's a huge database, but actually the data about the length of treatment for the different immunotherapies is very limited. So you can see here practically that, let me use this, that actually for children, if we include the ones that actually continue after discharge, we have only 47 children that they report the length of treatment and only 11 adults for anakinra, 40 and 22 for tocilizumab. And for intrathecal dexamethasone, we have a median for children about 6 injections and for adults about 5 injections. And for JAK-STAT inhibitors, we have only data about length of treatment in a couple of adults. So very, very little data. And these are the box plots actually to show that actually the mean duration of use of anakinra is about 32 days in children and much less in adults, it's about 13 days. While intrathecal dexamethasone, as I said, it's 6 injections and 5 injections in children and adults. And tocilizumab, again, the median is about 2.5 injections. So most of the people do either 2 or 3 injections, and some children have gone on to have up to 14 injections of tocilizumab, while in adults, actually, usually they don't go higher than 4 injections. And as I said, the JAK-STAT inhibitors is only from adults and vori from a couple of patients. So this is only, just to say that this is only about the length of treatment. There is no correlation at all or mention about correlation with outcome. So this is only just practice, what people tend to do once they start these therapies, and it doesn't prove that actually this is the right thing to do. Now, what is the evidence about the anakinra use in the chronic phase? I would say practically zero. There is the best case report, and it's only one case report that's out there, is from Robertino Di Lena and Anna Maria Veggiani's group, where they presented a 10-year-old boy who had anakinra at the chronic phase at 1.5 years after the onset of fires, but this child never had any treatment with second-line immunotherapy at the acute phase of fires. And actually, this is the most convincing one to say that anakinra made an effect in this child, because the child became seizure-free and for a few months, and then once the anakinra was taken away, the seizures relapsed. And that's the most convincing evidence out there for the use in the chronic phase. But very interestingly, all the papers that refer use of anakinra in the chronic phase, including this paper that was mentioned before by Olga, refer to patients who never had anakinra in the acute phase. And I have to say, this second paper by the Madrid group, I personally find it again quite poor evidence. From the 5 patients where anakinra was tried several years in the chronic phase, you can see here in this axis that actually this is 7 years, 3 years, 14 years after the acute phase of NORSE. Only 3 patients had some response, and only actually was a true responder with more than 50% seizure reduction. And this is patient number 5 here. I have to say, when you go into the details of the paper, it's not very convincing. I would say the paper also was not very carefully written. What you see here is not a mistake by me. Actually, it was the actual table in the seizure, and they have misplaced some of the numbers. So very little evidence. The second patient, actually, they said tried anakinra for a few months, and then they switched to tocilizumab. And after the switch into tocilizumab, there was some seizure reduction by 30%. Very, very poor evidence. Definitely not convincing. And the only paper that actually speaks about reuse of anakinra is this paper from Latvia. Again, very poor evidence. Child had acute onset of fires at 4 years of age. Anakinra was tried at that time at about 30 days, was not felt specifically helpful. So then it was aborted. And then at 8 years of age, when the child presented again in an acute phase with status or very prolonged seizures, they decided to restart anakinra, and they felt that there was some reduction in his seizure. Again, going into the nitty-gritty of the paper, not very convincing data at all. So practically no evidence. And the only paper that actually claims to have and show some evidence about the length of treatment with immunotherapy and correlation with outcome is actually this paper by the North Korean group that refers only to adults. They have 74 adults. I want to also, draw your attention to the fact that about 20% of them had non-convulsive status epilepticus. I think this is something that we need to discuss. I know what Larry said, but it would be interesting to discuss in a separate meeting if what exactly people label as non-convulsive status epilepticus. If these are patients in ICU where there is actually electroclinical decoupling and the brain fires away all the time, which of course is quite serious, or actually if patients are non-convulsive status epilepticus and can be fed and hydrated being out of ICU. So I think it's very important to discuss this, but irrespective of this, the main for me, the elephant in the room for this paper actually is that they support a model of treatment that is not used anywhere else, which is actually as first line rituximab for most of the patients, and then tocilizumab as a second line. You can see that actually 64 of the 74 cases took rituximab as a first line, and then 46 actually took tocilizumab as a second line. And they looked very carefully to 1 and 2 year outcomes, both with the MRS scale and a K score. This is a scale that the group created themselves for autoimmune encephalitis type of thing. This is quite a complex graph, but actually it says two simple things: that actually the patients that were on treatment with second line treatment with both rituximab and tocilizumab seem to be doing better in terms of improve more in terms of K score, which is the less score that you have, the better that you are, in comparison to the groups that took only rituximab or only had first line treatment with steroids or IVIG plus or minus Plex. And this is where they try to show that actually they showed that the patients who had treatment for 18 weeks or more, 12 and 18 weeks or more, seem to do better, to have a better outcome in comparison to the patients who had less treatment than 18 weeks. So they seem to put like a sweet spot at 18 weeks. And when they compared to patients who had treatment for more than 1 year, they didn't find any significant difference who the patients who had the treatment for less than 1 year. So that's where the sweet spot is. I have to say, this is a well-written paper, and I read it very carefully. And although the researchers try to control for a few confounding factors, I'm not sure at all if this paper would have survived a statistical analysis with propensity score, because one could also easily contemplate that a patient who there is a selection bias, and a patient that who is doing well, usually the treatment may go on for longer. So it's very difficult to say based on this, that this is an ideal duration of treatment. Now, can cytokines guide us? I would say, I would just say Orally has already published a lot of papers on this. I would say there's no clear evidence that cytokine can guide us. If I had to be very practical, I would say only that if one contemplates stopping the treatment, it makes it very difficult if your cytokines are still quite abnormal. So the only probably way that they can guide us is actually making it more difficult to stop the treatment if, for example, your IL-6 in the CSF is still quite abnormal. But otherwise, still there's no evidence to say that there is a correlation with the outcome. Is there a number of seizures that we should be allowing, and should be allowing for extrapolating evidence? It's interesting what also Larry said. Larry, from his side, he showed an adult paper about epileptiform activity burden in adults, and he put this cutoff at about 5%. The pediatrics like to quote this paper sometimes by Eric Payne and Cecil Han in Brain, again, reporting about critically ill children, actually putting the cutoff of the poor outcome at about 20% of seizure activity. That's about like 12 minutes in the hour of seizure activity. I would say, we have to be very careful about one extrapolating evidence. Even in the paper that Larry mentioned, it's quoted that actually some pathologies like hypoxic brain injury or other types of traumatic brain injury can have worse outcomes than other pathologies. But also we have to be very careful about causation and association. And we have this issue continuously in pediatrics as well, especially for hypoxic ischemic injury, for example, in neonates. No one has the true answer if the treatment of the seizures is actually beneficial or not. Actually, if that means that if the seizures are really just a side effect or an epiphenomenon of how the underlying injury is very severe. So I can only make some personal opinions and recommendations, as I said before, that if it's felt that anakinra is effective, then at least continue it until discharge from the hospital, or at least for 3 months, whatever is less. once you start tocilizumab, and unless you have very significant side effects like, I don't know, transaminitis or serious infection, then I'd say at least commit to 2 to 4 doses. I personally prefer weekly dosing and then decide on aborting if ineffective after 4 doses. Intrathecal dexamethasone, again, once commenced, I would say no less than 5 doses, and the maximum reported have been 8, although I know Olga has shown now two case reports where the team continued the intrathecal dexamethasone for more than a year. And the rituximab, I would say at least 2 doses, or at least until you make sure that CD19 cells are 0. I didn't touch at all on any side effects, and this what would prompt you to change the regimen and what to do when, for example, breast on transaminitis, because I think these are complex questions and will take time. I just want to give a shout out to the meeting that international monthly clinical meeting that now we are approaching 2 years since its onset. I'm very grateful to the colleagues from Texas Children because we started this meeting together, but of course we wouldn't be anywhere without the support from the adult colleagues. Larry Hirsch is always there. Laura Mantoni is always there, but also a lot of the international colleagues who are here actually in this meeting as well. And I'm very grateful for their support in this meeting. As IL says, we are a community of learners and we're still learning. We recently published actually the experience now after about 22 meetings or 23 meetings, were about 45 patients of acute and chronic fires that were discussed. As you can see, we're still missing a lot of the world, most of the world, but hopefully we're getting there. And what does the future hold? I would say collaborate, collaborate, collaborate. I don't need to preach to the choir here about the NORSE Institute and the European registry that are really trying to build the PICORI study. But also I would say reach out internationally to countries with other treatment models and compare our outcomes. And for comparison of our outcomes, that's where I think it's very important also to be very clear about our definitions as well. I review a few papers on fires, and I can tell you that not everyone actually has the same thing in mind when they speak about fires or not. And also, of course, the money of the published literature really has done a great job collecting all the published cases. And I know that Mike Eyre from Evelina Children's Hospital, in collaboration with Russell Dale in Australia and Hiroshi Sakuma in Japan, they have done an amazing work publishing on infection-triggered encephalopathy syndromes, and one paper has come out and the other is going to come out, and these are huge kind of databases to look at. And I just want to close by thanking all the clinicians that have shared their fires patients with us with a recent initiative that we had, and especially the patients and their families who actually agreed to be part of this study. And special thanks, of course, to the UK Fires team, and especially Professor Suki Wright and Dr. Dimitris Kapsas, who are very instrumental for the animal model. And I shouldn't forget, of course, Rachel Liu, who is the founder of Some Superheroes and who has been the soul of all our efforts for today. Thank you.
Thank you so much. There was a lot that you covered there. I think I just want to highlight one thing that you said about, what we know about the biomarkers and the cytokines, and that, right, it's hard when there is still an elevation to not want to continue or do something with that. And so I think just acknowledging that, yes, we check them, but what are you going to do with that information if you do check it and if you follow it when we don't have the data to say that how much that's influencing.
And if I'm allowed, because I wanted to mention it, I was prompted by a question that actually, I personally, if I was following a patient with the chronic phase of fires and they have a significant exacerbation of their seizures without any other clear-cut reason, for example, as we see in chronic epilepsy and triggered by infection that we know it's going to calm down, but we see them that they slide into status again, I would be very tempted of doing again CSF cytokines and serum cytokines and make a decision if I should give something again like anakinra or something else. And I have to state that for the chronic phase cases, actually, there's all the case reports that reported in the chronic phase, none of them had it in the acute phase. So that's another, for me, clue. If your patient or your child had NORSE fires and they never had it ever, I would again be very tempted of measuring cytokines, but also trying at least the immunotherapy for the first time in their lives.
Yeah, thank you. Do you mind, there's a couple of comments in the chat, Marisol. Do you mind answering some of those in the chat, and I'll move on. I'm going to talk briefly about quality of life. We've heard a little bit about it already, and then we'll hear from our families again about their experience. I do feel like the experience of patients and families is going to be, they're going to, really be able to describe this, and they know exactly what we're talking about. So I think I'm probably saying a lot of stuff that many people on this call are already, familiar with and are living, but I'll give a little bit of a background on some of the data and literature that we have about quality of life. And I think we titled this talk, perhaps the most important definition of outcome. All right, so I'm going to start. If people have a phone where they can do this QR code, just because quality of life is so personalized, individualized, I'd love if a screen will come up, and if everything works as it should, you'll be able to put in a word to describe what quality of life means to you. You can do it more than once, because I know putting in only a couple words might not describe it. And then on the next slide, it'll come up with a word cloud. And I just think I really wanted to see, from our group here, what one word what quality of life means to them. And once when I go to the next screen, I think you'll still be able to QR code, but I'll give everyone a little bit more time. Looks like everyone's looking down at their phone, and then this should load if it works like when we tested it before starting. Yeah, so everything, normal childhood, contentment, back to normal daily, agency over what you do, happiness, contentment, not having pain, having joy, balance, peace. And then with these word clouds, words that are put in more frequently end up being, bigger and kind of more emphasized. So seizure, freedom, and independence, it looks like are big themes in terms of as we're thinking about quality of life and what it means to people. All right. So when we think about quality of life in terms of, yes, you guys all just told me the words that come to your mind, which is really important. It's very personal. There is a few different definitions that come to mind, though, too. So the World Health Organization defines quality of life as an individual's perception of their position in life in the context of the culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. And again, that's why it's, individualized. It's a perception of someone's experience in their life, and is influenced by different things such as their culture and values. The dictionary describes overall enjoyment of life, general well-being, specifically the degree to which a person or group is healthy, comfortable, and able to enjoy the activities of daily living. And I bring this up because I think sometimes when, I will say clinically, when I ask patients about, how do you think quality of life is changing, I think that's probably not the best way to phrase it. And people might not know exactly what I'm asking or what that means all the time. And so, wanting to think through what we're talking about and what that means. So here is a separate kind of word cloud that I found online about thinking about quality of life with just some other words listed, but I wanted to see our own kind of personalized responses when thinking about NORSE and FIRES. This is a figure from interviews that we had done here of patients, and or if the patients weren't able to do them, their caregivers were able to do, or family members were able to do the interviews, really trying to look at the lived experience of patients who survive NORSE and FIRES. And a key theme that came out of that was thinking about quality of life, and our questions were looking at quality of life and how it relates to the experience. And what was really helpful, and what came out is that really the importance, yes, of seizures and health concerns and how much of an impact that can have on quality of life, but also these other things that I think are just as key. And we'll hear from patients and families, families at the end about their own experience and what influences and what they think of quality of life, but also think about mental and behavioral health and social and relationship factors, and really just acknowledging how much changes to friendships, family relationships, how there can be feelings of isolation, avoidance of activities, as we've heard about from some of the family speakers already, cognitive changes, needing caregiver support and or reliance, and just all of these different ways that are also, overlapping as well. And that's what this figure is kind of trying to say, is that you can't necessarily look at each of them in isolation, but there's so much overlap between these different factors that influence quality of life. There is increasing recognition that quality of life is important. So the 2020 epilepsy research benchmarks include a focus on understanding and reducing the effect of epilepsy and its treatment on health-related quality of life. We had also looked at and kind of prioritized important outcomes to consider with NORSE and FHIRS, and quality of life was something that came up and was identified as a key outcome to consider. And it's recommended for both patients and their caregivers at 6 and 12 months after initial NORSE presentation, then annually thereafter until stability is what a group of clinicians through some working group sessions and prioritizing key outcomes for NORSE and FHIRS. And then I just have these different articles up here acknowledging that there's many different ways to measure quality of life and several different scales out there, both for pediatrics and adults. And then there is a measure for patients with cognitive impairment that's called QI disability that was initially studied in pediatrics in some of our rare diseases and has been also used in some older populations now as well. And so, yes, it is something that is important to look at. I think there is not yet one measure that we know is best for patients with NORSE and FHIRS, although we have in the Yale Biorepository looking at quality of life outcomes, and then with the Combat NORSE study that Dr. Hirsch mentioned, do have quality of life outcomes in there as well. I think the area that we do need additional research is really, we talk about quality of life, and Dr. Tarashenko mentioned, how seizures impact quality of life, which, yes, we know that that does have an impact on quality of life. But what else can we do to help with quality of life, especially if you've also heard, discussions about some of the challenges in getting to, complete seizure freedom. And so if there is going to be some level of ongoing seizures and you're balancing that with side effects, what else can we do to help quality of life? And much of these interventions that are listed here are really studied in epilepsy. These are not specific to NORSE, but thinking about cognitive behavioral therapy, mind-body therapies, different exercise programs have been looked at, self-management strategies, educational interventions, relaxation techniques, and also improving our care that we deliver. So collaborative multidisciplinary care and case management support, as we've talked about a little bit already, and the importance of that. Again, I think there just needs to be more research and more also kind of structural changes in terms of some of these enhanced care models where we're able to provide those. And then I just want to put a few slides on as we think about parents and families. So it's important to consider the parental or caregiver quality of life, which can also impact the patient's quality of life, but then also acknowledging just what a significant impact NORSE and FHIRS has on parents. And I feel like I'm saying this to an audience where people have lived this. And so I don't know that I'm the one that should be sharing this right now. I will say in some research related to patients who have a history of status epilepticus separate from, yes, NORSE and FHIRS, falls into as a type of status, but, thinking more broadly, it didn't have to be refractory, that they, even in that literature, have found that caregivers of children and adolescents, when there's been a history of status, still experience social, emotional, and economic impacts. It's certainly compounded by patients when there is a rare disease as a cause of status. So that, fits right there with where we're at with NORSE and FHIRS. And caregivers describe a lack of social activity outside the household, difficulty planning social events due to caregiving responsibilities. And something I really just want to highlight too is that, monitoring for seizures and supervision and kind of the unpredictability is something that can be really hard and a challenge. And that's what we have heard in some of those interviews I did as well. And that life really can become more focused on providing care and supporting their child with NORSE, leaving limited time to pursue outside interest, social activities, feelings, and then having feelings of isolation and loneliness. I'll also touch on post-intensive care syndrome, which can be broken down. There's a kind of, you can think about it for pediatrics, but also for the family. So as a framework for conceptualizing the physical, cognitive, emotional, and social health impacts after an ICU or intensive care unit admission. And again, just mentioning that this extends to thinking about the family and the impacts on their social and emotional health. Symptoms can include depression, anxiety, and stress-related responses. And we know that there are certain risk factors or situations for PICs that will make that kind of more place you at risk for that. So thinking about the illness severity, the long-term impairment, a younger age of a patient. And then I also want to highlight just some of the hospital-related factors. So decreased satisfaction with communication or patient care. So I think this ties into, as we talked about communication on Tuesday, really some things that we could do to help reduce this impact on patients and families and caregivers in terms of thinking about how we're communicating, how we're interacting, and how we're supporting families. And I'm just going to add with a couple of other things about what we can do to help reduce PICS. So there was a paper that came out that talked about some interventions, including open intensive care units, having family member presence during ICU procedures, family engagement in care, keeping diaries, stress management training, and then also screening for these symptoms and referral to appropriate resources and support. So, we as clinicians are treating the patient, but I think we also need to be thinking about the caregivers at the bedside and the family members and how we are supporting them, or having, other members of our team thinking about case management, social work, being able to screen and help people get resources and support to help with this. And then Dr. Wong and Dr. Farias-Moeller put together these communication recommendations when we think about PICS and specific to NORSE. So recommending regular meetings with families, listening to families, asking the family to tell you in their own words, what is your understanding of your child's condition, providing education, and then inclusion in the intensive care unit. And so this can give us a little bit of guidance in terms of helping with thinking about the family and caregiver impact on their own quality of life as well, related to NORSE and fires. So in conclusion, again, we'll hear more directly from our family panel right after this, but NORSE has a widespread impact on patients that extends beyond seizures, impacting quality of life, not just of the patient, but of the entire family. There are, in patients with epilepsy, there's data that behavioral, physical, and psychological interventions may help improve quality of life, and that as clinicians, it's important to remember that early communication strategies and support can help reduce the impact on families. Ultimately, though, a key takeaway is that we need more research into interventions and resources to help improve quality of life after NORSE, and know, as we've talked some about kind of that post-acute or chronic phase, how can we help provide these additional supports to help improve quality of life during this time. All right. Let me stop sharing. And then again, I feel like this is something where I felt it was challenging to talk about, and our patients and families could really have done this much better than I just did. So I'd love to hear, from our family panel, and they can share their own individual experiences. Tara, I see you up. So do you want to go first? Sorry, not to put you on the spot. You have your video on.
See if I can not cry through this one.
Oh. And you can choose not to. If things, I just want to acknowledge that it's, probably been a long 2 days for everyone. So you can choose not to share anymore too.
No, it's fine. I don't have anything written, but I've been thinking about it. For my son, because he was nonverbal, and again, like I mentioned, that we didn't know what he knew about his condition, if he remembered his life prior to it, if he remembered me. I did my best to give him the best quality of care that I thought, or quality of life that I thought he could use, or I thought things that would interest him. I got him back into school, even though he slept through most of it when he was there. Struggling with thinking of my son in the condition that he was in, couldn't stand, couldn't walk, couldn't talk, couldn't eat. What would he have wanted for his life? Would he have wanted to be as he was, continually having seizures? He was happy. Like I said, he smiled, he laughed, he would flip you the bird for whatever reason, we don't know. Towards the end, he started crying, and we don't know why. Quality of life. I was like, does he know he's in a wheelchair? Is he happy how he is? I always had to assume what his feelings were and what he was going through. And in the end, that was the hardest thing, is to choose at this point where my son's at. If he were to recover there at the end in last November, would that be the best quality of life for him? And having to make that choice was the hardest thing I ever had to do. But in the end, I feel that would have been his choice as well, because he wouldn't have wanted to live in a vegetative state after what had happened to him towards the end. Being a parent and having to make these choices is unbelievable. Assuming what your child wants, assuming what you feel is best, assuming what they're feeling is the hardest thing. I gave up my life to give my son the best life for 1,063 days. Thank you.
Yeah, thank you for sharing again. Rachel, did you have anything else you want to add?
Yeah, I did have something written down, mainly because otherwise I just wanted to keep on track, otherwise I'll find it kind of difficult because it ends up getting emotional. So over the 7 weeks that Sam was ill, we tried every treatment, obviously to stop his seizures and save his life. But we as parents were suddenly facing, I suppose, the most devastating end of life conversation any parent could ever imagine. But at the heart of that was a conversation which was centered entirely in Sam's future quality of life. And similar to Tara, kind of Sam's clinical team no longer believed that continuing treatment was in his best interest and he would be in a vegetative state. So the focus of his care should now be on ensuring he died peacefully and with dignity. So for me, quality of life was no longer about Sam returning to the little boy he was before fires, because that was impossible. But on a very simple level, it became about whether he would still be able to experience consciousness, joy, comfort, connection. And most importantly, he wouldn't feel pain and he wouldn't feel fear, that he would still enjoy his life. And the conversation that we had with Sam's clinical team and from their extensive examinations pointed to the fact that this wouldn't be possible. But I think most conversations about quality of life focus on survival, rehabilitation, recovery, and adapting to the new normal. But for some families, quality of life becomes the question at the heart of the hardest end of life conversations they'll ever face. And I think that is where Northern Fire's family have the least information and support. There's very few resources to help parents understand how these decisions are reached, and very little to explain what meaningful recovery may realistically look like, and very little to help families understand how clinicians weigh the potential benefits of continuing treatment against the growing burden of the treatments. So parents are asked to place enormous trust in the clinical team while trying to comprehend the unimaginable. And as parents, our instincts are to fight, never give up. We fight for every treatment, every possibility, and every extra day. And that's how it should be. But I also think we need to broaden that to what it means to fight, because within our Northern Fires community, we often hear, never give up, keep fighting. And that's focused purely on survival. And these messages come from absolutely a place of hope and love and determination. That's so important. But I do wonder whether those words of never give up and keep fighting can sometimes make it harder for families to have those meaningful conversations about quality of life, and when treatment may no longer be in their loved one's best interests, because I think those words can have unintended consequences for those facing the unimaginable, the withdrawal of care. And for bereaved parents, the words can echo for years. Did I stop fighting too soon? Should I push for one more treatment? Was I strong enough? And I've asked those questions so many times to myself, and I still do. I battle this every single day. And when families are facing the unimaginable, they need support to understand how quality of life needs to become essential to determining what is in their loved one's best interest. Because sometimes fighting isn't about asking for another treatment. Sometimes it means putting aside your own unimaginable heartbreak and making sure every decision is guided by your loved one's best interests, their quality of life. So my takeaway message is this: that quality of life is not only about how someone lives after survival. And I think we need to be more open to having conversations about quality of life within end-of-life care and the withdrawal of life-sustaining treatment. And we need to better improve the support, education and resources available to families facing these life-shattering conversations, and also broaden our understanding of what it means to keep fighting and never give up, so that those messages continue to inspire hope for people still battling, but they don't leave bereaved families carrying unnecessary guilt like I feel. Thank you.
Oh, thank you also for sharing and highlighting again, such important key takeaways, even as you mentioned, have gone through the unimaginable. Nora, I'm going to turn things over to you.
Thank you. Thank you to all the parents and all the investigators in the room. Rachel, thank you for, as I wrote, addressing at the very last moment the elephant in the room. I think that that should be the topic of research and discussion, that we need biomarkers that can help families in this decision. Yes, we always want the best for our children, for our loved ones, but what is the best? And how can we decide when that best is not possible in the ICU or afterwards? So thank you, Rachel, for bringing that up. The other observation that I made is that the focus of the doctors in the ICU and afterwards is on seizure burden. But seizure burden, it doesn't seem like there's a consensus definition of what seizure burden is or how to measure it. And that seizure burden and how it is measured differs in the acute versus the chronic phase. And there's no clear line of demarcation between that either. So neither seizure burden nor function nor quality of life, those terms are not defined or discussed with most families in the ICU. And so I think that those are some of the topics of conversation, both within the investigators themselves and between the families and the doctors. I think right now what the doctors can say in the ICU is to tell families that when families ask, well, what are you doing? And why are you doing it? You can say that you're trying to stop the seizures because seizures can cause brain damage, death, and multi-organ failure. But I think you need to be candid that to say that seizures may not be the only driver in NORSE and that there's still so much uncharted territory. And stopping the seizures may not necessarily predict what the patient's recovery will be. And this explanation will show the families your educated intention while also grounding the family's expectation for the outcomes. But I think that this is a wonderful first step in getting everyone to talk with each other to relay what we each see in the treatment and living with NORSE. So thank you, Krista.
Yeah. I just want to thank you to everyone for attending and participating in the last 2 days. This session was really driven by questions that physicians struggle with and what we hear patients and families asking for in terms of some of the hard questions, as we've seen in the chat, some ongoing questions about what to do in these different scenarios. So I know there was data that we provided and some answers that we're able to give, but also acknowledging where the evidence still remains limited. Hopefully also still offering some hope for the future with some of the ongoing research and the information we have gained over the years as well. And so we'll continue to have more answers. I also hope this sets the stage for increasing collaboration and partnership between patients, families, clinicians, and researchers. I think especially thinking about some of the things that Nora just said and the key takeaways from our families today, I think there's such an opportunity for us to continue to collaborate and partner to help increase the care and improve outcomes for patients with NORSE and also better support families, including less seizures, but also thinking about other outcomes like quality of life. And then lastly, I really want to thank Nora and Jim for helping to organize this with me, and Jim for all your efforts in the first day and being on a panel again today. It really was a group effort. So thank you, everyone. Okay.
Thanks, Krista. Thanks, Jim.
Yeah.